Today, we are going to make frozen shoulder simple without making it shallow. Frozen shoulder is a capsule problem. The room around the joint shrinks. The common trap is this: it is not just weakness or laziness, passive motion is limited too. By the end, a patient should understand what is happening, and a resident should know what decisions matter. Start with the anatomy. For frozen shoulder, the important structures are glenohumeral capsule, rotator interval, synovium, humeral head, glenade, and surrounding cuff tendons. Do not memorize the picture as a list. Ask what each structure is trying to do when the person moves. In real life, the problem sounds like this: deep aching shoulder pain, night pain, and progressive loss of motion reaching overhead or behind the back. That story is the doorway into the diagnosis. It tells us which tissues are likely overloaded, irritated, torn, compressed, or failing to share load. The core mechanism is capsular inflammation, thickening, adhesions, pain-driven guarding, and staged stiffness. This is why two people with similar images can feel very different. Tissue appearance, load, inflammation, nerves, strength, and confidence all interact. For the lay viewer, the question is not, what word is on the scan? The better question is, what system is failing? For the resident, the question is sharper. What is the pain generator, what is the structural risk, and what can safely wait? A practical way to think about almost every orthopedic problem is tissue capacity versus load demand. If the load is temporarily too high, the answer may be calming and rebuilding. If the structure has mechanically failed, the answer may need repair, reconstruction, replacement, or protection. The common symptoms cluster around global stiffness, external rotation loss, night pain, difficulty dressing. Symptoms matter most when they form a pattern. One symptom by itself can mislead. A cluster is much more useful. Listen for timing, load, swelling, night pain, mechanical symptoms, and whether the person is losing trust in the limb. Also listen for what the problem has taken away: sleep, walking, work, sport, independence, or confidence. The best history is not a questionnaire. It is a map of what loads reproduce the problem, what settles it, and what function is disappearing. The exam should not be random. For this topic, deliberately check active and passive motion, external rotation at side, capsular pattern, rule out arthritis or cuff tear.